Hello.
Doing.
I have no idea when he's coming back. I have heard. Send me this.
Hi, Angel. How are you?
Hey,
Hi.
I think I was
Hi.
muted. How are
Sorry,
you?
I couldn't make it today. I've got two quizzes that are both hour-long quizzes I've been studying for. I gotta do.
That's
No
all
worries.
right. That's okay. Hi, Andres. Yeah. Yeah. Perfect. Perfect. Yeah. Perfect. Sure, you can show if there's time.
do you need help
Yeah,
as a
sure,
timer?
that's fine. If there's a time, if
Yeah,
there's time,
sure.
you can absolutely showcase this. That's okay too. No problem.
Oh, how long is your presentation and how?
5 minutes.
All right.
Yeah. Yes, that would be great. Yes. Can I text you? Because I'm about to start a meeting right now. Can I text you sometime? Yeah. Yeah. Yeah, we can work something out tomorrow. No problem. Oh, okay. Okay, see you soon. Bye-bye. If I think Anna sent out the email about our visiting surgeon, Dr. Dominguez, coming. Angel, did you get that email?
I think not. Let me check.
He I thought I didn't. I thought I meant to ask her to send it to.
Which email about the Colombian?
Yeah.
Yeah, I sent it.
Okay. All right. Anyway, he's arriving on Wednesday, but he's actually giving a Zoom vascular reference on Wednesday. If you all are interested in attending on Zoom,
Thank you.
just let me know. I can send you the Zoom link.
At what time is it? Because I will be actually in Houston.
Oh,
So
that's right. Okay. Is the meeting this week? I thought it was next week.
Next week.
Yeah.
Oh,
but
so
he's
you
coming
mean
this
this
week.
week? Oh, okay. Yeah, sure. I'll be there.
Yeah, this Wednesday, the vascular conference is 7 a.m.
Oh, sure. Yeah, I'll be there.
So, and then he's giving a similar talk on Thursday for the trauma group, but shorter, more focused talk. So anyway, just wanted to mention it. Okay. All right. I just want to make sure we've given a few people time to join. And
Sure.
Then we can
Just
start.
let
This is how long is this talk?
5 minutes.
Okay.
Yeah.
All right. And you have 2 talks.
I have no, I had 2, but I retracted the one for transplant. I withdrew it
Okay.
because I was working actually with his boss, and we couldn't get enough data to present it. So.
Okay. Okay. All right. Okay. Well, we'll wait for a couple minutes, and then you can start.
And who's joining?
I can
Anna.
see Anna, Leaf, Tan,
Hi.
Lara.
Hey, Laura.
Hi, how are you?
Good morning. Well, good afternoon. Are you in the same time zone? Is it noon over there?
It's 2 hours ahead of you. So it's 2 p.m. here.
Okay.
Which city are you in, Laura? I always forget.
In the capital, in Bogota.
Bogota? Okay. All right.
Yes.
Okay. I couldn't remember. Okay. Wonderful. Well, should we just get started?
Okay, sure.
Okay, well, welcome.
Thank you. Well, as you know, I will be presenting next week in the Academic Surgical Congress. I think this is a great congress and for people at my stage. And I will be talking about our project for breast cancer, in which I'm working with Dr. Brownson and Dr. Tuttle and Dr. Price. In this project, we are building a Virtual Multidisciplinary Tumor Board for breast cancer in Mongolia. We have nothing to disclose. And
Hey.
please let me know if you have any comments. I don't know if we should do that at the end or during
Yeah,
the
at the end.
presentation or okay.
Hey, I'm
Okay.
having
Yes.
your your screen. It's showing me the wrong screen.
Oh, is it showing the
Yeah, like the normal PowerPoint screen. It's not showing like the actual. There you go. Perfect.
okay. Let me see. Now I lost my notes.
Oh, I think I
but
can help you.
okay.
Here, 1 second. Let's go
Sorry.
back to where you were showing before.
Um,
Maybe the top bar. You said swap displays.
use presenter view.
Okay, and then let's do this. So little. Yeah. I don't know, how do you do this?
I can do it without notes. Doesn't matter.
Okay, well, if
Yeah.
you. if
We're
it's help-
seeing like the presenter view notes like screen.
I think I can get it in just a second.
Should probably learn like the actual
I
term.
think-
Use-
I think there's a way to do it.
Okay.
Here.
Oh, yeah. There you go.
What are you seeing now?
I'm seeing the screen I first told you about.
Let me see. Oh, but the thing is, if I do this, you're not going to see it here.
You can
Okay.
move it over there, but I
Can
can,
I?
however you want to.
Now let's just go back to where it was. Okay,
And you can also do it like this if it's easier to have your notes,
it's okay. I don't need the notes,
Uh,
actually. Yes.
because we want you to give your best.
Okay,
You want you to feel comfortable and give your best.
thank you. Let's see. Are you seeing the presenter's view or the correct one?
Yeah, I'm seeing a very zoomed in view of one of you, like the editing screen, but it's fine. Like we don't have to see it.
Okay. Okay. I guess this is what it should look. Okay. So Mongolia's population is over 3.5 million, 3.2 million, although the incidence of breast cancer is low. This incidence has been rising and the mortality rate is higher than anticipated with this disease. Unfortunately, 90% of cases are diagnosed in a late stage, leading to a high mortality with a rate of above 88% within 5 years. And an average of 250 breast cancer surgeries are performed at the National Cancer Center of Mongolia yearly. The implementation of multidisciplinary tumor boards has been shown to assist in decision-making and improve patient outcomes. The goal of our study was to describe the implementation of a virtual breast cancer multidisciplinary tumor board between 3 centers to improve breast cancer care in Mongolia. The virtual breast multidisciplinary tumor board consisted of 3 centers, one in Utah, one in Minnesota, and one in Mongolia, that evaluated 15 cases over a 12-month period. An initial survey was conducted to assess the availability and accessibility of the services and treatments, and a standardized template for case presentations was used. Recommendations were shared in a written document after each meeting, and data collected included demographics, tumor localization, staging, immunohistochemistry, treatment, and the recommendations done by the tumor board. Questions were categorized as treatment, diagnosis, or palliative care. This is the standardized template we used for the slides. Patient characteristics. A total of 15 breast cancer cases were presented. 100% of them sought care only after presenting symptoms like pain or palpable masses or skin changes. 2 cases were excluded after further pathology analysis revealed that breast cancer was not the initial tumor. Median patient age was 39 years old. 86% of the cases were diagnosed as invasive ductal carcinoma and 14% as metaplastic breast carcinoma. At the moment of presentation in the tumor board, 60% of the cases were in a late stage of disease, stages 3 and 4, while 40% were in early stage 1 and 2. 53% of the cases presented had positive estrogen and progesterone receptors. 60% of the cases presented were positive for HER2 receptors, and only 13% of the cases were triple negative breast cancer. 26% of the cases were recurrent tumors. Then, regarding the imaging and pathology, we can note that only 20% of the patients received mammography for diagnosis, and 60% were evaluated with ultrasound. And again, only 20% received both mammography and ultrasound for diagnosis, and 80% of the patients received a CT scan. However, CT scans performed did not include chest, abdomen, and pelvis. They were only chest or only abdomen. Some of them included chest and abdomen. For pathology, all 100% of patients were diagnosed with core needle biopsy of the breast. They are not performing core needle biopsy of nodes or sentinel lymph node biopsy. In treatment characteristics, 66% of patients who had surgery received neoadjuvant chemotherapy, 75% received adjuvant chemotherapy, 75% of patients with recurrence received salvage chemotherapy, and 66% of patients with stage 4 breast cancer received palliative chemotherapy. Among patients with HER2 positive breast cancer, 55% received Herceptin and none received Perjeta or a combination of Herceptin and Perjeta. Of patients who received surgical treatment for breast cancer, 75% received modified radical mastectomy, 25% received breast conserving surgery, and reconstruction at the time of surgery was performed in only 6% of patients. Among patients with estrogen progesterone positive receptors, 66% received endocrine therapy and 33% did not. Of 15 patients with breast cancer, only 13% received radiation therapy. In conclusion, virtual multidisciplinary tumor boards are feasible, replicable, and have a low cost of implementation. They can assist in decision-making process. Their standardization improves documentation, and written recommendations improve communication and follow-up. We were able to accomplish identifying areas of improvement. We established a network of global experts, and we found a way that can be done for a safe and innovative platform to impact clinical decisions in a limited resource setting. However, our future direction should include clinical staging improvement, de-escalation of surgery, observerships and training, and improved target therapy implementation in Mongolia. I would be happy to take any questions.
Nice work, yay.
Thank you.
I think despite, I don't know,
Maybe plus or minus
a minute
seconds, yeah.
at least.
I started it after kind of we resumed.
Okay.
Okay, so you're, yeah.
Okay.
Yeah, maybe a touch over. Okay, so let's start from the first slide. So very nice job. Your slides look beautiful.
Thank you.
Um,
I actually, one of the slides where I would like to ask all of you for recommendation is the results slides.
yeah, oh, believe me, we're gonna go through
yeah.
the slides.
Yeah.
So here's how I would like, and I don't know if everyone had a chance to take any
Doc,
text.
can I interrupt you for a second? I don't
Yeah.
know if it's just my like screen, but I'm looking at the background slide. So
Is this-
actually I couldn't.
Yeah, it's not just you. That's what I was trying to say. It was stuck on one slide
Mhm.
For the whole-
in like the
For the whole
edit
time?
of back of the whole time of the
Yeah,
background.
I found out
Huh.
in Google that you can click on the presentation option. Like if you click on the
Can you see it now?
I'm going to say it in Spanish. Yes. So, Ángel, si pichas ahí el botoncito, el normal, donde pones presentación,
Ajá.
abajo a la derecha, abajito a la derecha, como si fueras a presentar normalmente, ahí hay una opción que dice, vuélveme a compartir pantalla.
Ajá. Share screen.
Yes.
Okay. Microsoft PowerPoint.
So, in the right corner, down, go down, there should be
Yeah.
an option where you present the slides, like as usual. And then you will find an option that says, just,
Can you
Tipo
see it
pres-
now?
It's the same thing
yeah.
as it was. It's the intro
It's just-
slide now, but it's the same thing.
Intro slide?
Yeah.
Huh.
Not the title?
It's okay.
Yeah, it's okay. I can teach you that option later, actually, because it's useful
Okay.
for you to
Doesn't
look at
matter.
the presentation and also add the comments at the same time.
Okay, great. Thank you. Thank you very much.
But now you can see the title slide?
Yeah.
Yeah,
Right?
we can see the titles.
Yeah. You can stay on this view and we can,
Yeah,
we
that
can
works.
go slowly.
Okay.
Through all the slides. So, great. So did they ask you to use this slide background?
Not really. I had before the one from the University of Utah, but then I found this one available in the ASC guidelines. It was optional, so I
Okay.
decided to use it.
The only reason I'm asking is that it would be better if you do use the University of Utah, because that's sort of the main center.
Sure.
So you can also you can still have the academic surgical, the little logo. on it.
Yes. Yeah.
That's okay.
Okay.
So unless they mandatorily told you to use this,
Okay.
I would say that way it just gives the University of Utah some credit
Okay.
and visibility.
Okay.
And that's, that's important just because,
Sure.
that's where the work is stemming from.
Okay.
Okay, so that's one thing. I think you did this. The slide looks great. I think the fact that you have all the different centers and all the different authors, I think is fantastic. The mistake a lot of people make is they just put the presenter and not everyone else,
Mhm.
because it's not just you. You're standing there and you're reflecting the work of everyone
Sure.
that was involved. So that's really fantastic. I don't have any other comments on this slide. And you don't need to put like 18th annual academic surgical congress on there.
Okay.
You can leave that top blank.
Okay.
Anybody have any other comments? Questions? And you can
No,
also
maybe-
just use the
Maybe
last
you
name.
could out 2023, like the current year, maybe, like the
Yeah.
date
Okay.
of presentation.
Sure.
Yeah, the data presentation, that's a good point. Yeah,
Okay.
you should put the data presentation somewhere on there.
Okay.
And like I will usually put, you can also highlight your name on there.
Okay.
So and you can just use last names. You don't have to put the initials.
Okay.
But highlight your name, and then at the end of after Brownson, like
Mhm.
hit enter, and then ASC 2023 or something like that,
Okay.
just so that it's clear what where you're presenting, and just
Okay.
center that.
Sure.
So that's useful. Any other comments from anybody else?
And how the next slide, I was wondering,
Yeah, you want to go to
well,
the next
because
one?
you mentioned all three institutions here, maybe not the disclosure, but the third one. I guess.
Yeah, the next one over.
So there's a lot of space in the next slide. Oh, maybe it's future. Never mind then. If it's not adjacent, you would maybe the one after this. You've got the middle panel of the logos, which are nice eye candy,
Mhm.
but I feel like your information sequencing is
Mhm.
you talk about the institutions first,
Okay.
And if you don't need them here and you put them in your title slide, they could
Yeah,
probably go
exactly.
away.
Yeah, I
Okay.
would say, if anything, put all of this on the title.
Yeah, yeah.
The title
That
slide?
will make it look,
Okay,
immediately it gives a sense of
Yeah.
where places are from.
And then you can reduce off the list on this slide from 3 things of information, to
Yeah.
just your 2.
okay. Okay, any other comments?
Go back
Sure.
to the previous slide. Okay. For this one, when you say low incidence
Yes,
of breast cancer, do you have any sense of numbers?
yes, it's 6 to 8 per 100,000
So just
cases.
parentheses.
Okay,
That way you don't have to say those numbers,
okay,
but the numbers are there.
okay,
Because what does low mean, and a slash, not X.
okay.
And are those 3 bullet points, low incidence, 90%, 88%, are those related to these references in the bottom here?
Yes,
So just what I would say is make a little star at the end of each of these,
okay,
and then you can say a star or number.
okay,
Put numbers, and then just
okay,
put a number. And I usually don't put all this information about the paper on the reference.
okay,
It's just you can either pick the name of the person and the journal and the year,
et al. Yes.
or
Okay.
you don't even have to. It
Okay.
could just be like Martinez Journal,
Okay.
Journal American College of Surgeons 2023.
Okay,
Just enough so that if somebody was interested, they'll be able to pull it up, because honestly, they're not going to read all that.
sure,
And the only reason you're pointing it out to them is that in case somebody wants to go back and read those papers, they
Sure.
want to be able to find them.
sure,
So what is the key information that they're going to need? Probably author and journal and year,
okay,
kind of drill down.
okay,
Because probably there are not that many people
Okay.
publishing on whatever breast cancer in Mongolia in that particular journal
sure,
with that same last name on that year.
okay,
Yeah.
So you can find it easily. So that's what I would say, like, I don't know how to say that person's name, but Alguays,
yes,
global, and then you can just abbreviate global J,
okay,
QSH
okay,
or something like that. The journal also may have specific
Okay.
abbreviation, and just put in the year, like 2021.
Okay.
So that way it doesn't take up much space.
okay. Yeah, because I actually have other references here, so that way I could add all of them there because they are also referencing.
Yeah,
things
you can do
there.
that too. You
Okay.
can do that too.
Yeah.
You don't have to, but you can do that too.
Okay,
So I would minimize those references and then indicate which data came from which paper. if
Okay,
you have
sure.
that information.
yes,
So just put 1 or 2 or whatever.
okay,
So that's one thing. The other thing is that, so you kind of went from, okay, here's breast cancer Mongolia, to, okay, we now have a 3-institution multidisciplinary tumor board. And it kind of seemed like a bit of a jump to say, okay, well,
okay,
all right, why or where, how did this come, how did this get created?
okay,
You could say, we have a longstanding partnership from the University of Utah.
Okay.
These 2 institutions have
Okay.
a longstanding, or the 2 American institutions have a longstanding partnership in Mongolia, or something along those lines.
do you think I should,
asked to create a multidisciplinary tumor board to do X, Y, Z.
okay, do you think I should explain a little bit, like maybe 2 lines about what are tumor boards? What exactly is a tumor board?
No, you don't need to explain what a tumor board is. Everybody will know, the
Okay.
audience.
Okay,
But where and how you got to
Okay.
from this is breast cancer to,
Okay.
you could say these groups were all working together, have a history of working together,
Okay.
and there was a request
Yeah,
to
yeah,
create
yeah.
this tumor board. Sort of,
Okay.
that's your background, right?
okay,
Problem solution
Yeah.
kind of setup.
Yeah,
Yeah, those 2 bolded headings don't imply problem and solution necessarily. It could be like a list. So if you construct it like the response to the conditions of breast cancer in Mongolia was a multidisciplinary tumor board somehow.
okay,
Okay, and let's see. Go back to the previous slide. Anybody else have any input on that slide? Thoughts, comments from the group?
Yeah,
And
just
it's-
being like picky, sorry. Just with the title, you like align it to the edge? My OCD is kicking in.
This one.
To do
Yeah,
what?
I don't know.
Align it
Yeah,
here.
Oh, alignment,
Sure.
yeah, sure. Yeah,
Sorry.
the visual thing is important too. And then I think multidisciplinary tumor board is singular, no S at the end. The boards, look for the word boards, multidisciplinary tumor boards.
Oh,
Yeah, no S, because just.
Yeah.
Okay, all right, now let's go to the next slide. Okay, so this slide, a lot is going on. We've decided to remove the logos from the middle.
mhm.
So the methods, okay. You also, so you went through the methods a little bit. I was not sure who you meant when you said breast cancer specialists. And you could put in parentheses, surgeons, oncologists, rad onc,
Okay.
pathology,
Okay.
whoever, whatever specialties,
Okay.
right? So, so that people know, like, who
Okay.
do you mean, right?
Okay.
Or was there somebody missing, you know? So
Okay.
I think that would be useful to put. That's a thing we can put in a box,
Okay.
if you
in the
want.
space of-
right?
with those logos, yeah.
Exactly. So I think
Yeah.
that's a possible thing to do. The other thing is you mentioned a survey, and there's nothing on this slide about a survey or what the survey found.
Okay.
So that's also kind of the, like, how do you make some, is that a survey at the very beginning? Is that a survey after the 15 cases? Like, what?
It was a survey sent before the tumor board started, like the needs assessment survey, like how many surgeries they do per year, what treatments do they have available.
Great. So that should actually be in your background slide.
Okay.
So go back to background
Okay.
and let's talk about where you might want to put that, because
Okay.
that's one of the things that that you want to make the case. Like you said, breast cancer, big problem.
Okay.
We're asked to work on a tumor board.
Okay.
One of the first things we did was
Okay.
we did a needs assessment.
Okay.
And you can just say, you can summarize the top 3 points of the needs assessment. You don't have to talk a lot about it. You can say our needs assessment,
Mhm.
and verbally you can say, you know, here at the bottom. So like I would say, like after the tumor board, and say needs assessment, and put your 3 major findings. Is that part of your needs assessment? Is that?
Yes, some of the data that I actually didn't write here, but I mentioned, for example, the number of surgeries they were doing around 250 per
So
year.
that's the needs assessment. The literature is not the needs assessment.
Okay.
Right? The literature is a literature review.
Sure.
Right. A needs assessment is a survey
Okay.
of practitioners to say,
Okay.
what is the current system?
Okay.
So you can leave that background, the epidemiology, and you
Okay.
can say, you know, we were asked to assemble a multidisciplinary tumor board to do these 3 things. Although I don't know if we should put improve patient outcomes there,
Okay.
because I don't know if we can actually show that.
Okay.
And I don't know if this presentation will show any change in outcomes, right? Like
No,
that's a
yeah.
hard thing to show.
Mhm.
You know, you can say potentially improve patient outcomes.
Is this
that make sense?
something about multidisciplinary tumor boards in general? Or
What
these attributes,
what
or
I'm
these are
saying here.
of-
Yeah.
Yeah, or of this specific, or those goals of this specific one.
So these are the objectives of general tumor boards, like do case reviews, assist in decision making, and improve
So
patient
the
outcomes.
audience will know all
Okay.
about tumor boards. You're
Okay.
talking to surgeons.
Okay.
They all have been a part of tumor boards,
Okay.
right? Every single one of them.
Okay.
So you don't have to explain what a tumor board is,
Okay.
but you could say, you could leave that on there on how you can
Okay.
say we were asked to do these 3 things,
Okay.
right? Because that is also true. That's what
Yes.
the group, or we aimed to do
Yeah.
these 3 things, right?
Okay.
To say what was the goal. But before, and then you can say, but before we could just start that, we wanted to do a needs assessment, whether that's, if you want to put that in a separate slide or you want to put that here, you
Okay.
can do either one. You say in the needs assessment, we found that X amount of operations were being done, X types of resources were available, X types of gaps existed, things like that.
Okay.
So that you're painting the picture of what the problem is and what the context is, right? Because then if you say, okay, and then we saw, 20 patients, then the audience kind of understands what context.
Sure.
Okay. Thoughts from anybody else? Comments on how to lay out that presentation? Okay. So let's go back to that slide. Yeah. And I would say, instead of calling this standardized slide, you could say case template, for every tumor board or something like that, right? So you're more explicit about what this list means. So this is the template that we use, and you can say the tumor board is a virtual meeting of a variety of specialists. You don't have to name all the specialists because they're listed on there,
Okay.
or they will be. We met monthly over the last year. We discussed 15 cases. We used this standardized template, and you can just, you don't have to read off of them. You can just say this standardized template.
Okay.
It's already listed. And we created written recommendations, and that's fine.
Okay.
You're just kind of pointing to the data that's already on the slide.
Okay.
And any other comments on that slide from anybody else? Just before we move on. Okay, all right.
I have a question.
Yeah.
Just to make sure that I understood well. So the process was that you had virtual meetings, then breast cancer specialist, then monthly meetings, like 15 case presentations. At the end, written recommendations. Are these written recommendations for the slides, or like recommendations for the treatment or management of the breast cancer in Mongolia? Like what does that mean?
Right?
Yeah, they were recommendations for each case. Actually, I have that as supplementary
Okay.
information. We did recommendations for systemic therapy, pathology, imaging, and
It's a
surgical
great
management.
slide.
Oh,
That's a
okay,
great. If you can
Yeah,
put some of in there, that would be useful.
Okay.
I don't know if you cover all of this information, right? You were already a little bit over.
Yes.
Some of it is having information on the slide,
Mhm.
but not necessarily talking about it.
Sure.
Like you can just say, here, for example, here are the questions we were asked, and here are the recommendations that were given.
Mhm.
Pause for 10 seconds and move on.
Okay.
You don't have to describe it because it's already on there.
Okay.
So that way you can share information without having to
Okay.
take up time.
Sure.
What do you think, Laura? You think if that is in the results, you think that'll
Yeah.
work?
that is perfect. Actually, because my question was like, what are the themes of these recommendations? And the reason why I'm asking is because I am performing just a quick story. I'm performing a scoping review on the research stratified guidelines in medicine. And we found out that the big majority of the guidelines that are published are breast cancer guidelines. However, I'm looking at the table, the extraction data, there's nothing on Mongolia. So it's maybe interesting, a good point too. It's like an interesting discussion to say, we are responding to this need or the call for developing more like recommendations for low and middle income countries, but mostly like in Mongolia, et cetera, et cetera. So.
Yeah, I think that's a good point. It doesn't fit in here in these slides, but it may be at the very end. You could say, this experience could contribute to setting national guidelines for breast cancer, or better national guidelines, or more context specific.
Because they're already the NCCN guidelines. They already have like a focus group on low-income countries, but yeah, I could mention something about it.
Yeah, so just something to think.
I was just going to say that if you want, Angela, I can always share my table with you just to look at it and see.
I would really appreciate it if you can share it. Thank you. Thank you, Laura.
Okay.
All right. Anything else from anybody else before we go to the next slide? Okay. The question I had for this slide is, so these are the patients you discussed.
Yes.
And these are all the things that they had done before presentation at the tumor board?
Yes.
Okay. All right. So you may want to say that somewhere and say, patients had all of this workup.
Okay,
This is the workup patients had done,
Okay.
had, at presentation at the tumor
Okay.
board. Just so that it's not that the tumor board recommended any of these things, is that they already had all of
Okay.
these different things.
so this is like the patient status at presentation, right? Like
Uh,
when they were presented
When
at
the
the
ca-
tumor.
when the case was presented at tumor
Yeah.
board.
Okay, sure.
The other thing is CT scan. That's an interesting thing that's for sure going to be a question from the audience, because we don't usually do CT scans for diagnosing breast cancer.
Sure.
And you said some of the CT scans were abdomen CT scans. So
They-
were they where they were scanning the abdomen for some other reason,
For
and then they saw a breast cancer incidentally?
no, they were looking for metastases. but
Okay.
Yeah.
But okay, so the CT scans were not meant for initial diagnosis.
No, the initial diagnosis was usually with ultrasound. Well, actually, all of the patients, 100% of them came already with symptoms, either skin changes, palpable lesions, or pain. And then during their workup, they were evaluated mostly with ultrasound, and only 20% of them with mammography, and 20% with both of them.
Okay.
But 80% of them were screened for metastases with CT scan.
I think that's what
That's
you
the way
should
to say it, right?
That's the way to say it.
Sure.
Yeah,
Okay.
exactly. Because otherwise, I think, 80% had CT scan as their initial diagnostic test.
Sure.
That's not usually the standard.
Yeah, okay.
But for metastatic disease, absolutely. That's
Okay.
yeah. So just say that
In that way.
specifically. Yeah.
Okay.
Okay.
And how,
Yes.
I think this slide describes something interesting about the people, of the types of cases that are brought by the physicians in Mongolia to
Mhm.
the tumor board,
Yes.
and not just, like the general epidemiology of breast cancer.
Mhm.
So I didn't know if there was any kind of insight that you could offer, like this is, like these patients, these 15 patients are the kind of patients that are brought. Like does it surface any like clinical question or clinical like?
Yeah. Why did they bring
Because
these
those
15
ones,
patients?
yeah.
So I don't know exactly why they are bringing these cases, like specifically why not other cases, right? But I think mostly because when they are recurrent cases, some of them, 26%,
Yeah.
they have a lot of problem with those. Two of these patients were pregnant, so they had a lot of questions on what to do with pregnant patients.
That's a great
Yeah.
point to
Okay.
mention here.
Okay.
And you say, these are the cases that were discussed. And the reason some of these cases were being brought was because they were complicated. They were recurrent disease or in pregnant patients. And so the team wanted to reach out to an international group to get advice on care. And then, by the way, you can just say ERPR. You don't
Okay.
have to say estrogen and progesterone.
Okay.
Every of them.
Okay, sure.
So they'll just, again, fewer words so that you have more time to talk about other things.
Okay. And something actually just answering a little bit to that question. This is, I mean, our sample is small, but it's consistent with previous research that has shown that in Asia, at least in this part of Asia, the incidence, the peak age for breast cancer diagnosis is usually younger than in other countries like UK and the US. And that's actually something I'm talking about in the manuscript.
Yeah,
But
great.
yeah, because they have seen that the peak incidence is at least a decade before other countries.
Same thing in Africa.
Exactly, yeah.
Same thing. Yeah.
And
absolutely.
also, I mean, here it's not so evident, 60-40, the difference in the cases at presentation,
Yeah.
but it's usually described even more like 80-20 or.
Yeah, absolutely. And by the way, when you say, when you say, here are the patient characteristics, and you can just summarize. Patients were young, mostly had invasive ductal carcinoma, mostly had late stage disease, mostly had, were ERPR, half were ERPR positive, and more than half were HER2 positive. A small fraction was triple negative.
Triple negative.
So that way you're just summarizing.
Sure.
You don't have to kind of read out any of
Okay.
those. Okay.
And this is actually one of the tables where I wanted the most insights.
Yeah, so this is where I was confused because I was all of a sudden I was like, wait, are these treatments given after the tumor board, like based on the recommendations, or did patients already have this when
So
they were presented?
these patients already had this when they were presented.
Okay,
But the thing is that where I'm confused and I don't know exactly how to represent this data to make it clear is that we have different ends for everything. For example, because not all treatments apply to every patient, right?
Sure.
So
sure.
we shouldn't be counting like we shouldn't say like X percentage of patients received HER2 target therapy when it wouldn't be fair because not all patients require this
Exactly.
type of therapy, right?
Exactly.
So so we have different denominators for each one of these. So I don't know if I should put them here, like neoadjuvant chemotherapy, only patients who had surgery should be counted with neoadjuvant chemotherapy, right?
Yeah.
So this is out of 12 because only 12.
You can always
patients.
say N, and then you could say 8 divided by 12.
8 out of 12
Yeah.
like this.
Yeah.
Oh, okay.
Yeah, you just have to,
Okay, I'll fix it.
yeah, so you can do that. That's a way of describing like the denominator is not always consistent.
Okay.
And the key thing to say here is that, again, patients already had all of this at presentation,
Okay. Yeah.
at the case presentation, at the tumor board.
Okay.
And yeah, treatment characteristics at case presentation, you could say.
Good.
Because you got to the slide and I was like, wait, did you already, are these recommendations that were given, or like,
Sure.
how do I make sense of this?
Yeah.
Okay, so I mean, these are reasonable. The question then becomes like, maybe this is where you follow up with that supplemental slide you had about what recommendations were given, because that's the next natural step. It's like, oh, here are the complicated patients we discussed.
Mhm.
And what were the questions? What was the discussion? What was the summary?
Okay.
Would be the next logical step. So I would put those pie charts
Here
after the slide.
after the slide. Okay.
And you can say, we discussed blah, blah, blah.
Okay.
You know,
Yeah, most questions were about treatment and followed by diagnosis and palliative care and the
you can see most
recommendations.
questions were related to treatment.
Okay.
And then our recommendations were related to
Sure.
systemic therapy or further imaging.
Okay. Okay. Sure.
And help me go up above one more. Yeah. I wanted to know in this slide, because you did a lot of representing of the information in your words.
Mhm.
So we would see the text and you would describe the text as well. And that was eating up a lot of your time.
Yes.
And what I wanted was for you to highlight kind of a piece of information that you felt particularly interesting
Mhm.
and to give us insight as the researcher. Like, oh,
Okay.
we found all of this, but for me,
Mhm.
this is very illuminating.
Okay.
And put like sometimes like a red box around a piece of
Sure.
information.
Yeah, certainly. That's actually something that because I have a meeting tomorrow with Dr. Branson. I'm actually going over this exactly because one of the things that we could highlight is, but we also want to be very careful, like not to sound like very
Critical.
Exactly, like
Yeah.
we're criticizing how
Yeah.
they're treating their patients.
Yeah.
Yeah. And also we do not want to sound like we're just pointing out how like their areas of deficiency, right?
Yeah.
So
Yeah. You know, that's one of the hardest things is, you know, how do you raise the issues without sounding like you're patronizing them?
exactly.
At the same time, like
Mhm.
you have to raise what the main issues are so you can work on them.
Sure.
So, so you could, you know, you have to summarize, and I would suggest you summarize just like for each slide, you just want to make 3 points, right? Even if you have lots of data points on the slide, you
Okay.
want to make 3 points.
Okay.
So for this slide, you know, you could say, you know, here are the treatment characteristics of the patients who were presented at the tumor boards.
Mhm.
Most had had some form of chemotherapy.
Mhm.
You know, half had had Herceptin treatment. Most had had a modified radical mastectomy.
Okay.
Endocrine therapy had been initiated in 6 out of the 9 that were eligible, and radiation therapy in very few. So in one, like,
Okay.
so you could just say, I mean, that's probably 5 points, right? Not 3, but
Mhm.
you could kind of, you don't even have to talk about the endocrine radiation, like that's like self-explanatory. By
Okay.
the way, you should finish putting the percentages for radiation,
For reading. Oh, yes.
right? So,
Yeah.
so yeah,
Okay.
Okay.
Yeah, so actually I didn't put the percentages because I wanted to look at this with Dr. Brownson because
Gotcha.
I don't know what the denominator
yeah,
should
just
be
be
in this
question
one.
marks for now.
Okay,
So that you remember to put something in there.
sure.
Yeah, you're exactly right. You gotta
Yeah.
be very mindful of the denominator. Not
Yes.
everybody needs every single thing.
Exactly.
So, okay.
And then, well, we already saw this one. Any comments about this one? Color, size, further information?
Do you have a sense of whether the recommendations were enacted?
That's one of actually the biggest challenges because
So that should be in your slide at the end, limitations.
yes,
We don't know.
it is. Well,
It is?
I have it, but I'm going to say it, but it's not like
Fine.
yeah.
Um,
It's here. It's basically these two
Challenges.
parts.
Gotcha.
Because one,
Yeah.
patient communication is difficult because the infrastructure for cell phone telecommunications in Mongolia is not reliable.
Yeah.
So it's sometimes hard to contact patients that live maybe 24 hours away, like drive time, to ask if they are following the recommendations or the treatment indicated in Ulaanbaatar, in the capital. And also the lack of electronic medical record creates this
Follow-up data.
exactly.
Follow-up data.
It's very difficult for us to follow up the data.
Yeah.
Although we are developing a follow-up template to review
Great.
at each tumor board, where we review the previous case and ask to what extent were these recommendations followed.
Okay. That's fantastic. And you should probably put that somewhere.
Sure.
Like in progress, follow-up template, whatever else.
Okay.
So, okay, in conclusion, this was a multidisciplinary international tumor board. It was a low cost, but it had several challenges. Why was language barrier a challenge? A language barrier with the clinicians, you mean?
Yes. Yeah, it was sometimes a challenge because and this is where Leaf comes into play, right? He has been helping us sometimes ask for updates about where these recommendations followed or what happened with these patients, or if something gets complicated during the translation in the tumor boards. That's when Leaf helped us a lot to interpret.
So you can say we had several challenges. A key one was language of communication during the tumor board. Thankfully, one of our students was able to help be a translator.
Exactly.
And then second is patients live very far away.
Sure.
It's really hard to tell whether they were able to follow up on any of the recommendations that were given by the tumor board. And then last is there's no electronic medical record, so we can't really tell what the follow-up really is. But we accomplished these three things. One is that we identified many different. We learned a lot of different things about where there needs to be improvement. We created a great community and a process that is
actually,
robust.
I haven't seen the data, but during our last tumor board last week, the Mongolian team mentioned that since this collaboration started, I mean, it's subjective right now. They told me they have data, but I haven't seen it.
Okay.
But they said that their radical mastectomy rates have decreased, so they're doing less invasive surgery thanks to the recommendations of the tumor board.
That's fantastic, and you can say anecdotal.
Yeah.
It was sorry to add on to that specifically. It was 90% to 45% of their mastectomies that have decreased in the past 3 years since the start of the tumor board, and then the median.
Tumor board is 1 year.
Tumor board was 1 year ago, a little bit more than 1 year. So because it was started before I started doing this, so I don't know exactly like how.
Okay.
Much
so I would just say anecdotally, they through this process, they've actually started doing more what is the more breast conservation
Okay.
versus
Breast conserving surgery.
you know,
Okay.
yeah,
Okay.
modified radical mastectomy, but that data is being analyzed, something
Okay.
along those lines, just
Okay.
to indicate that there are some changes that that
Okay.
we're not discussing today.
Okay.
And so what, and then what do you mean by clinical staging and de-escalation? What about all this?
So clinical staging, this is one of the main things that we identified. There seems to be a confusion, and I don't know actually how to explain this again without sounding critical, but there seems to be a confusion between clinical staging and pathologic staging, because when we asked them in the templates to describe the clinical staging, they were giving us the pathologic staging, like after surgery, they were giving us what the pathologist found, but not the, like, how did they clinically stage the patient to decide the treatment.
So you could put some of that under the identify areas for improvement. You could say, for example, clinical versus pathologic staging.
Okay.
And so that way it's already listed there.
Okay.
You don't even have to say anything about it. And it just is an example of one area of work that needs to be looked at.
You have a limit on slides and how?
I do. What I've seen in previous years is that people
They're
go,
hard and fast,
yeah,
Well, because the strengths and challenges could be its own slide, maybe,
Yeah.
and give you more information to broaden out the accomplishments.
yeah. They recommend that you don't have more than 5 slides without counting title, disclosure, and questions slides.
Yeah.
Which I'm already at. If that's why I had this in supplementary.
Yeah.
Right now I have 6 counting this one.
Yeah.
If I put it in supplementary, I would have 5.
Yeah.
But-
I think you just have to reorganize that conclusion slide a little bit
okay.
and see how you can, and even like the next picture slide is not a slide you're going to spend much time
Sure.
talking about,
Mhm.
like that's your thank you question slide.
Mhm, sure.
Pretty much.
Yeah, and that one doesn't
So,
count. So.
Yeah, so really you probably have about five content slides,
Sure.
which is fine. I think you just have to organize this in a little bit. So identify the areas of improvement. These were the areas, for example, that we identified as, clinical versus pathologic staging. What about de-escalation of surgery? What do you mean by that?
Actually, what I was thinking about of doing less invasive surgery, because sometimes they are bringing patients in stage 4 cancer to the OR to do radical mastectomy, right? So when they should be going to palliative care or something like that. So encouraging the use of less invasive surgery.
Yeah. How can we put that in? I mean, honestly, you might just say like, surgical versus palliative care in advanced disease,
Okay.
Or management of advanced disease with
Okay.
surgery versus palliative care, something along those lines. It just indicates to the audience, like, this is an area that we're going to be looking at more in the future,
Okay.
which makes sense. If more of a huge portion of their patients are late stage, then really kind of figuring out plan for them
Sure.
is a good area of focus. And then observerships or training. You can just summarize that. Just say education
Okay.
related to these content areas,
Okay.
or related to areas of improvement, something along those lines.
Okay.
Target therapy, what do you mean by that?
Target therapy, actually, that one is because not a lot of them were receiving the patients who needed target therapy, not a great percentage of them received it. So
Okay.
There's some improvement there to make.
You mean like hormone therapy?
HER2-directed therapy for HER2 receptors.
Yeah. So you could do a couple of different things. You could say future directions or future educational opportunities and list, staging and clinical and pathologic staging, care of and late stage management of late stage malignancies, indications for targeted therapy, adherent. Like you could list those as topics of learning, right? Because that's what you're trying to say, is that those are areas
of
that,
learning,
that are learning opportunities. So you could also, instead of just saying
Adherence to
future,
guidelines or,
yeah,
okay,
you could, instead of saying future directions, you could just say future learning opportunities.
okay,
And list the 4 things that you want, that you think the group should probably focus on learning next.
okay,
Yeah. And I don't know if you need to put in a box for strengths and challenges. You could just say, you could probably put this like strengths, and you could just put all 4 words
okay,
in one line,
okay,
and challenges, 4 words in one line, like just to kind of consolidate.
okay,
So this slide needs a little bit of reorganization.
okay,
And Hal, I'm wondering about the word accomplishments. Is it better to say outcomes?
okay,
It doesn't matter. Accomplishments feels too quantitative
Yeah.
for me.
Yeah. I mean, I would even be more general and say like lessons learned,
Yeah,
Okay.
yeah.
because you're not measuring anything.
Right.
None of this is measured information. And you could even title this like conclusions, lessons learned. Here are the strengths, here are the challenges. And in the strengths, you could say, this is multidisciplinary, international, low cost. It led to identifying areas of improvement, it led to establishment of a global network of experts with a safe and innovative platform. And then challenges were these, and then our next steps are those. So
Okay.
that might be a way of
Mhm.
doing it. And you might think of that almost in the same way that you would think about writing the discussion section of a paper.
okay,
Because typically in the discussion section of the paper,
mhm,
your first paragraph is all about like, hey, what are the main findings of our project? Then
Yeah.
your next couple of paragraphs are, how does this correlate with what has been done in the rest of the world?
okay,
Which you're not putting in here, but you could if you wanted, if you had time and space. And then you talk about what are the limitations of this project, and then you talk about, well, how does this, what does this mean for next steps, whether it's for policy or education or research or whatever,
okay,
And so that sort of template for discussion is sort of what you should be using for this
okay.
part of the talk.
Thank you.
Yeah. Any other comments from others and on any of that? I think these pictures are great.
Would there be any value putting this slide like first or early?
You could.
I wanted to, I actually had this picture at the beginning instead of this one, but Dr. Brownson wanted to change those. So,
It's fine. I think it's fine either way. It
Yeah.
doesn't matter.
Yeah.
You and Dr. Branson can work it out.
Okay.
And then do you have any other slides after that? Or is
just
that all?
this one, but I still have to review this one with Dr. Brownson.
No problem.
Yeah.
No problem.
But this one is about, this is more for the manuscript that we are writing in parallel.
Yeah.
We're going to talk about the change in staging from actually the clinical stage, where they didn't provide the clinical stage, but Dr. Brownson and I were actually able to determine it based on the information in the presentations, not for all of them though, because
Okay.
for some there was not enough information.
Okay.
But for what we have right now, 20%, there was a 20% change in stage from the diagnosis to the actual surgical pathology.
Okay. Okay.
And yeah, this one is just because I sent it to
You might want to, in your thank you slides, you might
Yes.
want, in that slide, you might want to acknowledge your mentors.
Okay.
So I would say specifically Brownson, Tuttle,
Okay.
Price, and maybe Segerling. Or any other, relevant mentors.
Okay.
And then you can just say like, and the teams.
Okay. Sure.
It's always nice to kind of recognize the fact that there are people who are supporting you.
Yeah, sure.
And the reason why I mention that is that those are all well-known names,
Sure.
and you want people to walk away saying, oh yeah, of course, Ray Price was involved in this, or Kirsten Brownson was involved in this project, and he is a mentee of that person.
Okay.
And I know that person. And so, I think
Sure.
he's a good guy.
Okay.
So you want to always leave them with that impression, because again, like, everybody has certified their match list and everything right at the moment.
Yeah.
But you always want to keep sending the message that you're a credible, trustworthy person that really good people are trusting and mentoring.
Sure. Yes.
Like keep selling that story.
Yes, I will. Thank you.
I probably shouldn't be on this paper. I have not contributed to this project at all.
Okay.
I'm happy to add.
Well, you're contributing right now.
But not really.
Okay.
But I'm happy to be like just you can you put me in the acknowledgement. It doesn't matter.
Okay.
It's just more like really anybody who's been involved, especially over the course of the
Yeah.
project. Yeah. So. Because every project that we're working on, not every, like we're all in this, not necessarily on it.
Sure.
But
Yeah, and this is a manuscript that since this
Yeah.
project was accepted for presentation at the Academic Surgical Congress, we have special consideration for submission at the Journal of Surgical Research or Surgery.
Yeah.
But the deadline is Wednesday, March 1st.
Yeah.
So we are kind of, we have a close deadline. And
Yes.
I will write the abstract at the end. I already have introduction, methods, results.
Yeah.
Still working on the results with Dr. Branson. Actually,
Okay.
this is going to be part of our talk tomorrow. And
perfect.
also Dr. Pride will be there. And unfortunately, Dr. Tuttle won't be able to join us, but
That's okay.
we will.
Yeah. Great.
And here is what we're going to talk about: the patient age that I was
Yeah.
mentioning, main status of breast cancer in Mongolia,
Yeah.
early detection, breast tumor boards, like
Yeah.
what is already known and
Yeah.
what we
Yeah. Perfect.
already found with our results, the standardization, because there's also evidence about standardizing the slides
Yeah.
and about the written recommendations, clinical
Yeah.
staging.
Fantastic. This is going to be a very nice paper. I definitely encourage you to finish it and submit it by March 1, because the acceptance rate is much higher.
Sure.
If you submit it, if you wait another month and submit it to the same journal,
Okay.
like they usually, you still have, as long as you still note that you had presented it, they'll still
Sure.
take that into account. But it's really important to try to make it.
On time. Yeah.
So I think you've already written most of it. This is great.
Yes.
You've done a really nice job. And it's good experience.
Thank you.
Any other thoughts or comments from anybody else? Okay.
I just want to say good job.
Yeah.
Yay.
Team, right? Yeah,
Thank you.
nice work. Any other thoughts, comments before we disband for the day? Okay. All right, cool. And
Thank you.
you have Leaf's name on the paper and abstract?
Sure.
Okay,
Yes.
all right, just want to make sure. Okay,
Yes.
cool. All right, great.
Done.
Well done. Have a great trip, and
Thank
then
you.
see you guys next week.
Thank you. Yes.
You did a really nice job.
Yeah, I'll be leaving Monday afternoon and coming back Thursday.
Okay.
Thursday, I think.
You have all the things that we arranged are good to go, your
Yes.
slides and books.
Slides and everything.
Okay.
Yeah.
If you can, when you're there, she may or may not attend this meeting, but see if you can find Laura Esserman.
Laura.
Esserman,
Okay.
Esserman.
Okay.
She is a breast cancer. You should look her up. She's a
Okay.
breast cancer surgeon at UCSF, and she is like a world leader in breast cancer
Okay.
research.
Okay.
She's phenomenal. She was actually has intermittently been one of my mentors during residency, and since I finished, I haven't kept in touch with her as much.
Okay.
But she is like world renowned.
I'll look for her.
And she has an MBA from Stanford, and she runs all these like massive international studies. She had a Nigerian surgeon or pathologist back in 2005, I think, come to UCSF to present the pathology behind breast cancer in Nigeria. Like at a time when it wasn't even on the radar for most people in the US to think about what breast cancer looked like in any other part of the world. So like she is an incredible, and like she's really, really well known. So just somebody for you to say hello to, and
Sure.
If you see her, you can also say that, I told you to say hello.
Okay.
Because again,
Hmm.
we want you to look good in front of as many different people as possible.
Yeah, a lot of progress.
And she's, well-established person, and she knows me, and
Sure.
so,
Yeah, thank
so
you.
just something to think about.
Thank you very much.
And you can even mention the story of, I said, I still remember this Nigerian, physician who talked about breast cancer in Nigeria and how late stage of pathology that, she had as an invited speaker.
Sure.
And it just, those kinds of stories about people,
Okay.
people like to hear, I don't want to sound manipulative, people like to hear about themselves, right?
Sure.
And so like that was still an inspiring experience.
Mhm.
It's something that I'm still talking about like 15 years later,
Sure.
right? Says something about her and her vision, and so that's an important thing to recognize.
Well, for sure. Thank
So,
you.
but yeah, she's a good person. It's a really good meeting. You've been
Yeah.
last year.
Yes, I've actually, this is the third time I present in this meeting.
Good.
And I presented before when I was working with Dr. Rodriguez. And
Yeah.
I really like this meeting. And
It's a great
actually,
meeting.
I told Leaf that he maybe should go next year. Because last year when I was there, I saw a lot of medical students and even undergrads attending there, because there are all these events for
Yeah.
mentoring. And so it's a great conference. I love it.
Yeah.
Yeah.
I've been on the executive council for those societies, and I'm still on some
Yeah,
national committees for some of those societies.
I really like this meeting.
And
And
It's-
especially because also you get to know a lot of people your age.
Yeah.
You get to do networking with people who may end up in residency with you.
Yeah.
Or
And you get to, and all the people who go there, even for faculty and chairs, like they're all really very approachable.
exactly.
Like,
Yeah.
as a junior faculty, it's like I'm having drinks with various chairs of departments from across the country.
Mhm.
I'm like, that's great. So like for faculty, it's great to kind of
Mhm.
meet those guys. For surgical residents who are graduating looking for jobs, it's great to, it's one of the few conferences for people who are interested in surgery at academic institutions and not private practice. Like ACS is much more private practice oriented.
Mhm.
But if you want to get for residency or a fellowship or a job,
Mhm.
like this is a conference to go to for any field, because it's one of the few conferences that's across all disciplines in
Mhm.
surgery.
Mhm.
So aside from going to like ILTS or SAGES, which are very specific,
Mhm.
this one is broad. Like
Very
you can
broad.
meet the pediatric surgeons, you can meet the transplant surgeons, you can meet basic scientists, you can you can meet anybody.
Yes.
So that's a really good exposure standpoint. So
And actually, something I was thinking about, I don't know if we will have the time. I think we could make it, but taking, for example, the paper that we were doing with Sarah Schoenholz, the geospatial location of for breast cancer treatment in Africa.
yeah,
I think we could do it something similar to add to this paper, like where are these patients coming from and what is their drive time in Mongolia, right? Because we've lived it, and like 18-hour bus rides to get like, and this is something I discussed even with Liv when we were there, that imagine like we were complaining about this 18-hour bus ride and we are completely healthy and we were having fun and everything. Imagine having to ride a bus for 18 hours or sometimes even more, and being sick, and you don't have anyone to care for you or your family.
And sometimes I wonder if some of the patients are coming with their kids. Because
Exactly.
they probably don't have somebody to take care of them potentially, or
Exactly.
there's definitely some real challenges. But yeah, you could even just with these 19 patients, you could do that.
Exactly.
You know,
Find the
you could do
locations
that.
and
Yeah, you
I
could
think that's something
do
we could do.
a map. It may be a little too it may be too difficult to do in the next month for this paper.
Sure. Mhm.
But you could
That could be a follow-up paper.
you could be a follow-up study entirely. You could if you could get a hold of these people, these 19 people,
Mhm.
and ask them what their drive time is, what their cost of accessing care. You could apply the 3 delays model
Okay.
of accessing care, which is looking at like decision to access care, and then process of accessing care, and then once you get to care, like quality of care.
Mhm.
But you could absolutely apply that to say, here's a set of patients that really are complicated patients. And here is their, here's what their access to care looks like, here's what the cost of care looks like. And that in itself could be a useful paper, because then you could say, these are the challenges faced by people with really complicated disease. And if you were to create better access for those patients, like what could you do? Granted, it's a small snapshot, but it may still give you some ideas of which part of the country or what issues are most concerning. Is it cost of care? Is it distance? Is it transport accessibility? Whatever.
Sure.
So you might think about all those different things.
Good job.
Thank you.
Yeah. Okay. Cool.
Very nice.
I will go talk to Ihan Lin about this connection with the innovation people. All right. Nice work. You're going to
Thank
be
you.
awesome.
Thank you
Keep us all posted.
for all the feedback. Thank you.
Yeah.
Bye. Thank you. Good job.
Bye.
Anha.
Bye.
Nice to see you. Thank you.
Bye,
You-
thank you.